Now, we all know that how important is it to learn mechanical ventilation, particularly not only for the intensivist, but I believe it's important for every graduate, because when you are working in the emergency departments, when you are working in the ICUs, when you are working even in wards, there can always be a situation where you may need to deal with critical patients and may need to put a patient on ventilator or manage, whether with or without a specialist support. So the topic today would be to judge on the to dwell on the basics modes of ventilation. So let me start. What is respiration? As per the definition, it involves the exchange of gases between oxygen and carbon dioxide, between organism and the environment. Now we all know, this is we have world learned in our physiology in second year of MBBS, that there are two types of respiration: external and internal. External involves the exchange of gases between alveoli and pulmonary capillaries. So the gas comes into the alveoli, reaches the pulmonary capillaries. That is external respiration. And internal is when at the cellular level, when the movement of oxygen happens from capillaries into cells, and that is why this is called as internal respiration. So this is how the gas exchange happens between in the body. Now this is what happens in a normal respiration. When we are taking a normal breath, like a negative pressure ventilation, what happens is, as soon as we breathe in, the normal respiration is a negative pressure ventilation. So the intrathoracic pressure or the intrapulmonary pressure, it actually becomes negative. And when it becomes negative, we all know air flows from a positive pressure to a negative pressure side, and that is why during inspiration the air goes in. What happens when we expire? We all know exhalation is a passive process. So what happens is, the chest wall actually goes back. There's a rise in the pressure inside the thorax, and the gas moves out. Now this is what we call as physiological respiration, or the normal way of respiration. But what we do in mechanical ventilation? In mechanical ventilation, in critical care, it's known that it's a non-physiological way of respiration, because normally we are taking a negative pressure respiration, but when we are doing a mechanical ventilator, we are pushing air from air from outside, and that is why it's called a positive pressure ventilation. So it is not only unphysiological, and that is why it can also cause damage to the lungs. So it's very important that we understand the nuances of mechanical ventilation when we are managing these patients. There are 2-3 pressures which are most important when we are managing the ventilator patients, but they are also relevant in our normal physiology. One is the trans-airway pressure. As you can see the name, it's the pressure between the airway opening and the mouth, which is mouth, and the alveoli. So when the gas is moving from mouth into the alveoli, it has to cross a pressure in the airway, which is known as trans-airway pressure. It is denoted by the term PTA, and it's PAW. AW means airway minus P alveoli, which is ALV. Now this is a normal pressure, but when you put them in the ventilator, when they put patients on the ventilator, it is the amount of resistance that the air has while passing through the trachea, the 2 main bronchi, and then till the level of the alveoli. So the airway of the human body offers some resistance to the air going inside, and that is known as the trans-airway pressure. The other is the transthoracic pressure. Now the air has already moved into the alveoli. Between the alveoli and the body surface, that is the chest wall, there is a pressure gradient, and this pressure gradient is known as transthoracic pressure, which is denoted by PTT or PW or P small t. All these are transthoracic pressure. So it shows the amount of pressure required to expand or contract the chest wall. So the first air pressure was to overcome the airway resistance. The second pressure that the ventilator needs to overcome is the transthoracic pressure between the alveoli and the body surface. So this is the amount of pressure required to expand the chest wall. And the most important pressure is the transpulmonary pressure. Even if you cannot remember any other pressures, the transpulmonary pressure is the most important. What is that? It is the pressure between alveoli and the pleural space. So there's an alveoli, then you have a lung, outside that you have a pleura. Between the pleura and the alveoli, the pressure is known as transpulmonary pressure. And this is the most important pressure, as I told you, also known as alveolar distending pressure. Means alveoli ko open karne ke liye, if you want to open the alveoli, the amount of pressure that you need to apply is known as transpulmonary pressure or alveolar distending pressure. Now look at this in a diagram. As I told you, from the mouth till the alveoli is called as transthoracic pressure. From the alveoli till the pleura is known as transpulmonary pressure. And from the alveoli to the chest wall is known as transthoracic pressure. So these three pressures are the most important pressure that one needs to understand whether it's a normal respiration or a ventilated patient. So if you look at the transpulmonary pressure changes, as you can see, there is a negative pressure ventilation and there is a positive pressure ventilation. So when we are breathing in a normal way, the transpulmonary pressure or the intrapleural pressure, it becomes negative, and that is why the air goes in. And when we are exhaling, it becomes less negative. So it's not that during exhalation the intrapleural pressure is still negative. As you can see, it's -5, but it's less than intra during inspiration. So the air comes out. What happens in a ventilated patient? In a ventilated patient, as you can see, the intrapulmonary pressure is all positive because you are pushing air from outside, and the transpulmonary pressure is also positive. It's 10 -2 because it's the difference between the alveolar and the pleural. So as you can see, the intra-alveolar pressure is 9 to 12. So we take it as 10, and pleural is 2 to 5. We take it as 2 -2. So 10 -2 is equal to 8. So the transpulmonary pressure of pushing air into the lungs comes out to be 8. And the reverse happens during expiration. So please understand that this shows that the pulmonary pressure is not only the most important factor, but it also shows that you have a higher transpulmonary pressure, the chances of damaging the lungs are more during mechanical ventilation. So as I told you, this I have already discussed during normal and during exhalation. Now, the other concept of ventilation that one needs to understand is the compliance. Now, what is compliance? Compliance of a structure can be described as the ease with which the structure distends. So suppose you have a balloon and you push air into it, the balloon inflates immediately. Can you put air into a stone? No, because the compliance of the balloon is much better than the compliance of the stone. So what is compliance? Compliance is the ease with which we can inflate the lung. So it's shown as change in volume. If you will push air into the lungs, there is a change in volume, isn't it? Which is known as the tidal volume. So the change in volume divided by the change in pressure. So that is known as compliance. For example, if you want to inflate lungs, you have pushed in certain tidal volume, which is measured in liters or milliliters. To push that tidal volume, there's a pressure that is required, and that is known as the pressure. So the division of volume by P is known as the compliance. This is a grammatic diagram by which you can say on the x-axis you can see there's a pressure which is transpulmonary pressure, and on the other axis you have lung volume. So the blue colored graph that you can see is known as the pressure volume loop. And this graph, as you can see, is the normal graph where For a change in pressure, there is a change in volume. Every time the pressure goes up, the tidal volume also is delivered. Now, what happens if the compliance goes down? The graph will move from blue to red. So the graph moves downward and rightward. So that means the compliance is gone down. And even by looking at the graph on the ventilator, you can say, oh, the compliance has gone down. What are the conditions when the compliance goes down? ARDS, pneumonias, pulmonary edema, fibrosis. In all these conditions, the compliance of the lung goes down, and so immediately you'll get to know, oh, this is the lung is behaving badly. I need to make certain changes in the ventilator. So this is compliance. Compliance is extremely important when you are on a ventilator. In fact, when you have put a patient on ventilator, you should note down the compliance of the lungs at that point of time. Suppose you have put a patient on ventilator and the compliance is 15, and after 2 days the compliance goes down to 6. That means the lungs have actually gone bad. So it's very important that you have a complete target of which way the compliance is going. Similarly, you can have situations where the compliance is high. These are situations with increased compliance, and here the graph goes left and up. Conditions are most commonly are COPD and asthma. So COPD is a high compliance, COPD and emphysema. These are high compliance diseases. So your ventilatory strategy for a COPD is completely different from your ventilatory strategy for ARDS. And that is why we say that the compliance is the most important factor for us to determine how to ventilate our patients. As I have told you, this is how the compliance behaves. So the take-home point 1, which as students one must know, that what is the normal compliance? The normal compliance of us, any normally breathing spontaneously human being, is 50 to 170 milliliter per centimeter of water. But for intubated patients, the compliance is about 40 to 50 in males and 35 to 45 in females. So how do you measure the compliance on the ventilator? This was more of physiology. On the ventilator, what we do is, we always have tidal volume. Suppose we have given a tidal volume of 400, which is denoted by the term VT. Then you have a plateau pressure, which is visible on the ventilator, and a peak. Let's say you have delivered a tidal volume of 500 ml with a plateau pressure of coming as 25 and a peep of 5. So it's 500 25 minus 5 is 20, and 500 divided by 20 comes out to be approximately 25. No? So the compliance of the lung is 25, which is not normal, but you should know that this is how we calculate. Now, most of the ventilators today automatically give you the compliance, but in case you are not able to locate that, you can even measure the compliance